Uh, Namaskar and welcome to today's session of Critical Lines. So this is a new form of education that we are starting. We were doing all these webinars for quite some time, and now we are starting this Critical Lines, which is going to be a podcast in which leading experts from a country will give their opinion on various issues in critical care. This will be a short session of around 20 minutes. So we are starting our first session today, and this is going to be every Wednesday at this time. And we are really honored and pleased to have Dr. Subramanian Swaminathan with us for the first session. Sir has taken previously two very nice lectures for us, and the videos are up there on our YouTube channel, and all of you have viewed it. And I'm really honored to say, sir, that they are the most popular videos on our channel. And Dr. Swaminathan needs no introduction. He's known to all of you. He's one of the leading IIT physicians in our country, and he's a great educator, and really thank him for the time he has spent with us on our platform. So, sir is Director Infectious Disease at Gleneagles Hospital, Chennai and Bangalore. He's also the chair of Infection Control Advisory Board Group, Gleneagles Hospitals. And he's the Vice President of Clinical Infectious Disease Society of India, amongst many other things. Briefly, sir is a great educator and one of the leading IIT physicians in our country. So we'll start off with a few questions, sir, and this is, I think, would be very important to everybody. So the first question for you to throw light on is, sir, about sepsis. So which is the commonest thing? So we have a septic shock patient coming in toward the ICU, sir, and initially we do not know what is the bug, what sensitivity, etc. So first, for Indian ICUs, what kind of antibiotics should we choose and how should we dose them? And also about ICUs with the resistance is less in other countries. What kind of antibiotics and what dosing empirically?
Okay. So when we look at the surviving sepsis guidelines, which is good but has its limitations, let's first understand a couple of things. The idea behind that septic shock bundle is meant for septic shock. It's not meant for sepsis. So when people go around saying that within 1 hour you need to get the antibiotic in, that is meant for septic shock. In sepsis without shock or organ system dysfunction, you do have a little bit of time. So you can step back a minute and ask yourself, what is happening? Where is my focus? What is my microbiology? What is the usual resistance pattern? And therefore, what would be the ideal agent? So let's keep that in mind. So we should not be treating every sepsis as a septic shock and therefore run in gut splicing. So when we look at community-acquired sepsis, the commonest cause of community-acquired sepsis coming into the ICU would be urinary tract infection, pulmonary infections, pneumonias and things like that, skin and soft tissue infections, intra-abdominal infections, and then tropical infections. So this would be the major. Of course, there are always going to be endocarditis and a few other things that happen. But from the infection point of view, the most common ones are these. In a urinary tract infection setting, what you need to remember is you need to get an agent which has very good activity in the urinary stream and has been shown in studies to be effective. So most people would worry about what is the commonest organism, E. coli and Klebsiella, E. coli being more common, and ESBL is very, very common in our country, and therefore you need to treat it appropriately. The question is, should it be piperacillin tazobactam, cephalosporins sulbactam, or should it be meropenem? Unfortunately, after the Merino trial, it's very clear the preferred choice for a patient in septic shock should probably be a carbapenem. And then once the culture comes back, you de-escalate down to a BL-BLI. If a person is not that sick, meaning patient is relatively stable, there is no obstruction, patient is not in septic shock, patient is not profoundly immunosuppressed and so on, you may get away with a BL-BLI. Now, which BL-BLI? Should it be piperacillin tazobactam or cephalosporins sulbactam? Both of these have some limitations, especially because they don't cover AMP-Cs. And AMP-Cs are increasing as an important cause of beta-lactam resistance even in the community. And therefore, the new antibiotic, cefepime enmetazobactam, may be a good option. It's a very interesting molecule, and I think it has value in these kind of patients. Alternatives, let's not forget the role of aminoglycosides like gentamicin and amikacin, but then most people would be uncomfortable using those drugs. For a pulmonary infection from the community, the most common would be streptococcal, pneumococcal, and of course, in post-viral, sometimes staphylococcal. So ceftriaxone is considered pretty adequate. If you have a post-viral scenario where the patient is sick, then ceftaroline would be superior. In the Focus 1 and Focus 2 trial, ceftaroline was not as good as ceftaroline is better than ceftriaxone, even for pneumococcus, and it has MRSA coverage. Why am I talking about ceftaroline? Because this is one option to avoid using drugs like meropenem. Because in our ICU, there's a lot of pressure on meropenem. So for pulmonary infections from the community, we can use a drug like ceftaroline. Keep in mind that we are seeing an increasing number of mycoplasma coming from the community. This is worldwide. And that the reason why it is important because today the mycoplasma is becoming resistant to macrolides. So you cannot trust your azithromycin and clarithromycin for atypical cover, especially when mycoplasma is considered. So preferred option would be ceftriaxone with doxycycline. If the patient is sick, we go for ceftaroline with or without doxycycline, and that's our preferred choice. That way we keep off the meropenem. The third would be skin and soft tissue infections, where it's usually staph and strep. Obviously, we're not talking about the post-traumatic or bite-related or diabetic foot infections. Those are a whole different gambit. But for the most part, it's staph and strep. And there you do need to have an MRSA cover. So you may go for vancomycin or teicoplanin with BLBLI, or you may even go for a single agent tigecycline if the patient is not very sick. There are multiple options. You can choose between any of these options. Finally, intra-abdominal infections. Well, unfortunately, let's say it's a pancreatitis or a hollow viscous rupture or a liver abscess. Yeah, again, the same problem applies where you have gram negatives in the mix. So carbapenems are very often the preferred agent. So this is a place where carbapenem use cannot be avoided. The idea is to start a carbapenem, do a source control, and quickly de-escalate as much as you can. Tropical infections, I'm not going to go into each and every one of them. Salmonella is increasing in frequency. We are seeing more and more salmonella in the urban space, both in adults and in pediatrics. What is important to note is that if you're worried about salmonella, do not use ceftriaxone. Ceftriaxone failure is becoming more common. Your go-to drug would be either high-dose azithromycin, 1 gram once daily, or cotrimoxazole. But in certain situations, we've even been forced to use things like chloramphenicol.
Right, sir. Thank you, sir. Then moving on to so one question about the dosing. If the patient has acute kidney injury or CKD, what kind of dosing would you advise initially? Should we reduce it or initially?
Okay. So this is a common problem, isn't it? So yeah, to make it even more interesting, sometimes it ends up being a patient with acute and chronic renal injury, and then you may have to adjust even more. It's an even more difficult adjustment to make. The first point is it doesn't matter what the renal function is. The loading dose for every patient is the same. It is weight-based or age-based or whatever it is. So if you have a patient with chronic renal failure, with acute or chronic renal failure, whatever it is, and if you're planning to use amikacin for some reason, give them the first dose as the first full dose. So if it's a gram of amikacin, it's 1 gram of amikacin. It's 2 grams of meropenem, it's 2 grams of meropenem. Please do not scrimp on the first dose of the antibiotic. That is just to saturate the system. Following that, the adjustments for renal dysfunction should be done with some amount of thought in mind. If it's only chronic renal failure, then it's easy. The dosing algorithm is absolutely correct. On the other hand, if it's acute renal failure, there is often hyperfiltration that happens, and therefore you may be underestimating the renal function, and you may be massively underdosing. So generally speaking, please be a little liberal with the antimicrobial dosing. And after all, let's be honest, more people die of septic shock than they do of antimicrobial excess.
Thank you, sir. So then moving on to the second question about PCR multiplexer. So now we have again patient of sepsis, septic shock coming in, and we send the blood culture. The yield is not very good, but PCR is supposed to have very good yields, maybe up to more than 90% in fact. So PCR is not in the guidelines for sepsis guidelines, which were published 2 years ago. So should we send PCR for everybody, sir? Do you think? I mean, is it cost effective and the results, etc.?
So the problem is this. The point is, while we may say PCR, we don't know how good this PCR works. And many of these things don't even have a validation cohort. So please understand, blood is a notorious PCR inhibitor. So when you do PCR directly on whole blood, it is very difficult to amplify and find out what's happening. And therefore, that's why most commercial systems have been struggling when it comes to direct PCRs on whole blood. And therefore, most of the systems are based on a blood culture enrichment followed by a PCR. So when people tell me that their direct PCR works brilliantly, I have to ask myself, Arey Baba, are we really sure? So, and in the absence of a validation cohort, your guess is as good as mine. So, for a whole slew of reasons, I stay well away from these multiplex PCR systems because we don't know what it means and how it affects my decision making. Second, with a multiplex PCR, you can only detect things you're looking for. I'll give you an example. Let us say you have a badly controlled diabetic who's a farmer who comes from central India or eastern India with fever and sepsis and septic shock. One of the concerns you should think about is milioidosis. And if Burkholderia pseudomallei is not in the PCR list, you're not going to find it. For example, this is a problem even with film array, biofire. It does not have milioid and therefore it will not be picked up. So you'll only pick up what you look for. You may not pick up everything and anything. Therefore, please be careful that even with validated systems, there are obviously limitations to this. So I am not using any PCR-based system. I'm only making clinical decision-making algorithms, and I find it to be quite adequate. In once in a blue moon, maybe we may use PCR-based systems to augment what our traditional systems are doing, never to replace what our traditional systems are doing. And I think we need to strengthen our traditional systems by sending enough blood for culture. One of the reasons why a pickup is poor because patients often get antibiotics before the blood culture is taken. And the second is not enough amount of blood is sent. So in an adult with septic shock, 40 ml of blood is the recommended sample to be sent for microbiology, not 40 ml blood in a bottle, 10 ml in each bottle, aerobic, anaerobic, aerobic, anaerobic kind of thing. So with that, the pickup is actually pretty decent. Yes, it's not perfect, but I'd rather not deal with a system where I don't know what to do with the result. And when I see Acinetobacter comes in the community, I know there is a problem. And I have had my own horror story with some of these systems. So for various reasons, I am not using any of this right now.
Thank you, sir. So your comment on biofire, sir, you talked about standardization. So biofire is supposed to be standardized and everything FDA approved.
Correct. Okay, so but then even that is not perfect. I'll give you an example. I had a patient with a solid organ transplant recipient, kidney transplant recipient, who presented with headache and fever and whatnot, and basically was a meningitis. Now, when you have a meningitis and a post-kidney transplant, one of the things you're looking for is Cryptococcus. Now, the team had already sent off a biofire film array meningitis panel, and it had not shown anything. I said, no, it is still Cryptococcus because you need to understand the performance characteristics of all of these. There is something called limit of detection. So if your pathogen is below the limit of detection, you will not pick it up. I'll give you an example which everybody can understand. When you look at HIV RNA PCR results, it will say up to 20 copies per ml or up to 40 copies per ml or something like that. If it is below that, you will not pick it up. It doesn't mean it's not there. It is just that it is not above the level at which it can be picked up. So in a multiplex PCR, you need to have a higher level at which it can be picked up. And Cryptococcus in solid organ transplant is a beautiful example of how it may be missed even if it is there. I had another young man who came to me, an intern himself, with fever and diarrhea and all kinds of weird symptoms, 3 weeks of illness. And I was convinced he had salmonella. His blood cultures were negative, his stool cultures were negative. We even did a stool biofire. The stool biofire did not pick up any pathogens. I was not convinced about it because salmonella is in the list. Since he had GI bleeding, he had a colonoscopy. Colonoscopic biopsy culture grew salmonella typhi. So please keep in mind that you have to look at all of these and also understand what are the performance characteristics of these tests. You can't expect the test to be 100% perfect in all circumstances. Even a HIV test is not 100% accurate. We all know about false positive HIV reports. Same way, there can be false positivity, it can be false negativity. False negativity is a significant issue in certain targets. For example, Cryptococcus. So you have to know that. And the best thing to do is talk to your microbiologist, or if you have in-house ID, talk to them. They'll be able to guide you because some of this stuff is going to be very difficult to remember.
Thank you, sir. So then just moving that forward, tropical infections. For example, you have Leptospira, Rickettsioses. What tests we have are not reliable. So serology is not reliable.
Yep.
So, and even the performance of these tests in Leptospira and Rickettsioses is themselves not well described. So what about these PCR in these infections, sir?
So the point is that I still believe the best test is your own clinical acumen. If it follows the clinical, if epidemiology is there, and the clinical presentation is consistent, I would always back my clinical acumen over all these tests. Like example, that young man who had salmonella. My team and I, we were convinced of salmonella, although the primary team was asking us, are you sure? Are you sure? Because everything has come back negative. We backed ourselves and said, nothing doing, this is only salmonella, and we gave him only azithromycin. They wanted to give him some meropenem and all that because he had high fever. I said, nothing doing, this is only salmonella, do not worry about it. And finally, we were vindicated because the culture, the intestinal biopsy culture showed salmonella. But the point is that we need to understand that every test that you order has a sensitivity, specificity, a positive predictive value and negative predictive value. The positive predictive value and positive predictive value especially is a function of the epidemiology, meaning the prevalence in that population that you're testing. So therefore, it's a lot of mathematics involved. So please keep in mind that any test that you order is subject to all these vagaries. And therefore, if you like maths, and most doctors got into healthcare because they hated maths, I suppose. But I always look at the mathematics of it and try and estimate how accurate this result is. And it's a good exercise to do because that tells us exactly what we are doing. But it starts with the pretest probability. When you have a patient with a result, you have to ask yourself, does this look like Leptospira? Does this look like dengue? And that's where most of your result hinges. So while these tests are nice, none of these are foolproof. Unfortunately, that's how it is going to remain. No matter what you do, there is going to be an Achilles heel for every test. Like, for example, if you're looking at HIV, there's always going to be a window period. So things like that will happen. What will serve you well is always your clinical decision making.
Thank you, sir. So then moving on to the next question. So there are certain formulations in our countries like meropenem, sulbactam, and ceftriaxone, EDTA, sulbactam. I've been asked this many times by our colleagues, junior colleagues, what to do with them because they're not used in the Western countries. They're not FDA approved, and even in our country, I don't think they have been subjected to vigorous trials.
So these are very useful molecules. These are very useful for the pharmaceutical industry. Now, question is whether it's useful to us and to the patients. That's a different question. So the point is that they don't offer any additional value. So when you have somebody marketing meropenem with EDTA, meropenem with sulbactam, it's just garbage. I don't even bother about those kind of molecules. Why am I using all of that? What is it that I'm trying to do? See, the first point is always, what is my target? If I do not know what my target is, I'm basically throwing stones at the mango tree. That's not helpful. Always define what you want to cover. Okay, this is a pyelonephritis. I think it's an ESBL based organism. And I think Merino data applies. And I think carbapenem is the right answer here. I'm going to give meropenem. Awesome. Otherwise, you say, this is a patient who's been in the ICU for the last 1 week. It may be a line-related sepsis or maybe a catheter also with a urinary tract infection. In this setting, I expect a carbapenem-resistant organism. In my hospital, I usually see Klebsiella. That's my primary pathogen. So therefore, I need to cover for CRKP, in which case meropenem sulbactam doesn't make any sense. So my option should be either ceftazidime or polymyxin or whatever it is. So if you look at it that way, you realize there's really no space for any of these drugs.
Right, sir. Thank you, sir. So then moving on to the next point. So what are the recent developments, sir, in the diagnosis and treatment of Candida infections, and especially with the spread of resistant Candida auris, sir?
Yeah, that's a really scary one. So good news is there are newer drugs which are coming out in the antifungal space. Bad news is none of them are going to come out in India fairly quickly, and it's going to take time. So we only have 3 groups of drugs when it comes to Candida. You have the classical azoles, fluconazole, itraconazole, posaconazole, voriconazole, and isavuconazole. Then you have the echinocandins, caspofungin, micafungin, and adilofungin. And then you have the various forms of amphotericin B. In the Western world, they now have rezafungin, which is a once-weekly echinocandin. And of course, they also have ibrexafungar, which is a different category of antifungal. So again, that's again for vulvovaginal candidiasis, but it works for Candida auris as well. The point is that we still need to understand that if you have a sick patient in the ICU with candidemia, and if you don't know what the susceptibility is, an echinocandin is the gold standard. And both the European and the American guidelines are very, very clear on this. The reason is because when you look at secondary endpoints, echinocandins are superior to azoles. Does that mean that I give echinocandin every time? The answer is no. If the patient has a low probability of fluconazole resistant and the patient is not very sick, I don't mind starting directly on fluconazole. If the patient is sick and if I don't think there's resistance, echinocandins are superior. So let's keep that in mind. The point is, there are situations now we are starting to see weird infections. Like, for example, what did you do for Candida auris meningitis, neurosurgical meningitis? Well, there are options like intrathecal echinocandins and things like that. Flu cytosin does have some amount of adjunctive activity. So this is the kind of situation where you should reach out to an ID physician to help you with it, because each case is different, and I don't think it's a one-size-fits-all. For the most part, what I would expect all intensivists to be aware is, if you have a candidemia and the patient is sick, start an echinocandin, get repeat blood cultures. A week after you clear the blood cultures, make sure you see the eye. At the time when the blood cultures are clear, think about de-escalating to an oral azole and make sure that the patient gets out fine. Pull the lines and all that stuff. But if you have something more complicated than that, it is best to reach out for help.
Yeah. Thank you, sir. Any developments in the diagnosis apart from the clinical aspect and the blood culture?
Yes. Yeah. So basically, we have new methodologies. One is the serological diagnosis like beta-D-Glucan. Problem with beta-D-Glucan is that it has a very good negative predictive value. So beta-D-Glucan, again, there are lots of commercial kits which are available. All of them are completely useless. The only beta-D-Glucan system which is reliable is the one from Cape Cod, Massachusetts. The fungitel assay. That one is good. But even that, you have to be careful, because if the beta-D-glucan is very low, it excludes candidemia. There is no cutoff at which you can say definitely not candidemia, and a number above which you say definitely it is candidemia. It is an ROC curve. The higher the number, the more the likelihood that it is candidemia. What is even more interesting is a rise in number. Let us say you do a beta-D-glucan today. It comes back as 100. And you do a beta-D-glucan after 4 days, and it comes back as 200. A rising number is consistent with the candidemia rather than a single number. Problem is, most places don't do it on a daily basis. It is fairly expensive, and you still need cultures to know the speciation and confirmation, all that stuff. So beta-D-glucan has not gained a lot of traction. The second one is what is called as a T2 Candida. It's an mRNA-based system. You need a special system which is insanely expensive, and it only identifies about 6 different species of Candida. Again, this will also need reconfirmation with culture-based diagnostics, and therefore it is not yet prime time. So unfortunately, all the Candida systems that are currently available right now are not yet prime time. One more thing with the beta-D-glucan is that the beta-D-glucan can be elevated in many other conditions. For example, we had a high-profile person with enterococcal endocarditis, and enterococcus is very well known to elevate beta-D-glucan very, very high. Other thing where beta-D-glucan is significantly elevated is pneumocystis pneumonia. So if you have a HIV infected or a steroid-based patient with pneumocystis pneumonia, beta-D-glucan is a great way of assessing if that's a possibility. So beta-D-glucan is more like a broad fungal PCR, which is positive in a lot of different situations. It's not unique for Candida.
Thanks, sir. So then, next question: what specific considerations are required for managing infections in immunocompromised patients, like transplant and malignancies, and being on an immunosuppression drug?
That's a whole different situation and pretty complicated. So not every immunosuppressed patient is the same. For example, if you take dengue, solid organ transplant patients do very well with dengue. It's actually quite mild in solid organ transplant. On the other hand, stem cell transplant recipients, dengue can be killers. So obviously, it's not the same for everybody, even if they are significantly immunosuppressed, because the type of immunosuppression and the setting also makes a big difference. In general, obviously, infection risk is higher and outcomes are poorer. But there is a recent paper which has showed that bacteremia with sepsis and septic shock in solid organ transplant, survival is better than normal people. So paradoxically, the theory is that immunosuppression actually reduces the counter-regulatory efforts of the patient to harm themselves, and therefore probably blunts the mortality in those kind of people. It's a very interesting concept, and a lot of discussion is happening about it. So it's obviously not the same. Stem cell is obviously the worst, where outcomes are really dangerous, and you really don't want sepsis. So in these kind of people, there are general timelines that we use. So when do we see bacterial infections? When do we see viral infections? When do we see fungal infections? Which kind of fungal infection do we see early? Which kind do we see later? How do we use prophylaxis? How do you assess the use of prophylaxis and the modification of the disease pattern in the setting of prophylaxis? Environmental exposures, a lot of the, organ, how is the primary graft working? Is there any rejection? Has there been other immunomodulatory infections like CMV, which have been part of it? So all of this comes into the discussion. And I think this is the kind of stuff where you're better off discussing with an infectious specialist. Lots of data sets have shown that if you have a transplant-related sepsis, if you get ID transplant-related fever, forget sepsis, fever, if you get ID involved within 48 hours, you reduce cost of care and also improve survival. If you get them involved within 5 days, you don't reduce cost, but you improve survival. So it is strongly advised that if you have a specialized situation, the best thing you can do is reach out to a friend of yours who's an ID guy and ask them for help.
Thank you, sir. So then the last question, sir, we have these patients, sir, of long-standing severe diabetes, CLD, PKD, or multi-organ diseases. Now, and they get infections with sepsis or whatever, different kinds of infections. So are these people, this subset of population predisposed to more MDR infections and more virulent infections?
In a way, yes. I'll explain it like this. It's not by virtue of them being immunosuppressed, but it's by virtue of them being around healthcare and around other patients who carry these kind of bacteria. So are patients with, say, chronic liver disease and transplant more likely to have a multi-drug resistant organism sepsis? The answer is yes. Why do they have that? It's because they are permanently in and out of the hospital and they are permanently exposed to antibiotics that we stimulate the colonization with multi-drug resistant organisms. In fact, recent data has shown that patients with liver disease, when they develop TB, it is more likely to be quinolone resistant TB. Why is that so? Because they've been using fluoroquinolones for SBP prophylaxis. And when you use quinolones for SBP prophylaxis, obviously the TB that you get is going to be quinolone resistant. So let's keep that in mind. The point is that these are patients who are in and out of healthcare settings. These are patients who get too many antibiotics at the drop of a hat. Some of which is clearly avoidable. And therefore, they have a very high probability of developing a multi-drug resistant organism sepsis. And obviously, when you have an MDRO sepsis, survival is definitely poorer than somebody who has an infection, which is more easily treatable.
Thank you, sir. Thank you very much. I think we have covered the very important points, and I think it'll be great learning to everybody. And Dr. Swaminathan, sir, thank you very much from all of us, educating our country every day, day in and out, sir. Thank you very much, sir.
Absolutely. Absolutely pleasure. Thanks for having me.
Thank you, sir.